PNR104, Week 1, Introduction into Nursing, covering Chapters 1, Nursing and the Healthcare System, Chapter 2, Concept of Health, Illness, Stress, and Health Promotion, and also covering Chapter 3, Legal and Ethical Aspects of Nursing. All right, so to get started, and to elaborate on my previous lecture, nursing is a time-honored tradition. Nurses can date back to before Florence Nightingale. However, we give credit to Florence Nightingale as she is the founder of the nursing practice. The key word in there is practice. In order to practice, we must have licensure. In order to have licensure, you must have nursing education, which includes didactic, which is your lecture portion, clinical, which is your hands-on portion, lab, hands-on, simulation, which incorporates real-world scenarios in a safe and monitored environment. All those incorporate getting licensed as a nurse. Each hour you're in lecture goes towards your license. Same follows for labs, clinicals, and simulation experiences. So back to Florence. We talked previously regarding her epic experience during the Crimean War in Crimea. How she took soldiers, cared for them, the wounded, the sick, the dying, in the dreary, dark, and cold areas of the war that they essentially stored these soldiers. They basically took them, threw them in a dark place, very limited food, hardly, probably zero sunlight. What does that do to the mental state of a person being in a dark, secluded area? It's not good. It can bring on depression and other manifestations. What does dark also do? We can breed bacteria in dark, warm environments. Okay? Not good, not conducive towards healing, essentially meeting health and wellness. And that's what Florence Nightingale did. She changed that. She went in, she provided the sick sanitation. She cleaned the areas that they were in. One of the most time-honored forms of sanitation is hand washing. It's one of the #1 ways to prevent infection to self and others. So she cleaned the barracks, sanitized them, took note of that. She wrote it down in her ledger. She also incorporated sunlight as for a regimen to the sick during the war. Sunlight can do bountiful things to the body, one of which in babies can reduce jaundice. Sunlight also brings upon different emotions, happiness. There is research that involves sunlight and a positive aspect to the body. Okay, but why does this all matter? Well, you can't know where you're going until you know where you're coming from in nursing. Okay? And again, that's just a brief touch on what we talked about during our lecture in class. So now I'm going to continue on in a new aspect, covering, I'm going to start covering chapters 1, 2, and 3. So the Nursing Practice Act, that defines the scope of practice. An LPN has a different scope versus an RN. An RN has a different scope versus a nurse practitioner. A nurse practitioner has a different scope versus a medical doctor. All of these govern how we are able to work and operate under our licensure. The LPN and RN do not write prescription medicines. We do not have a license to provide a prescription or write a prescription, but we can provide care, absolutely. And we'll get into that. Okay. So, continuing on chapter 1, I've talked about Florence Nightingale, but I also want to talk about the 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 importance that she put on, and this is also taught in the England School of St. Thomas Hospital. That's one of the first hospitals that was started for nursing training. Excuse me, first training schools, not hospital. She promoted that nutrition is an important part of care. Fresh, clean air is beneficial for the sick. Sick people need occupational and recreational therapy. That nurses should identify and meet the needs of patients, hence reducing the risk, like we spoke about as well. Predicting risk can benefit patients. We have a sixth sense, essentially, or a nurse gut, or critical thinking that tells us if a patient, for example, if they are walking with a walker, okay, and maybe they're a little weak too, would you want a patient with a walker walking over a carpet that has no grip to it and they might fall, right? It becomes very slippery, especially on like a tile floor. Could you just picture that for a second? We'd like to reduce the risk. We want to teach patients to remove throw rugs or hazards in the home environment, in the acute care environment, in the long-term care environment. Okay, back to this. So we are a distinct and separate practice from medicine. And now, historically, nursing was taught by doctors. However, new evidence-based practice suggests nursing is best taught by a nurse. And nursing education is a lifetime event. It's not a one and done. Although it can be, we should strive for greatness in nursing and honor the tradition of the calling. Okay. Interestingly, nursing in North America was lacking during the Civil War. Okay, so Dorothea Dix came around. She was a social worker, and she basically organized volunteers again to care for soldiers, mostly built up of mostly women. Clara Barton also took on volunteers in the field, in the battlefield, to help care for soldiers in both sides of the army during the Civil War. Did you know that Clara Barton founded the Red Cross? Now you know. Fun fact of the day. Lillian Wald. Thank goodness for Lillian Wald. She started community health nursing. We briefly touched on this in class. And in 1983, her and Mary Brewster established the Henry Street Settlement Service in New York City. This focused on the needs of poor people, so poverty-stricken environments, okay? That's in the period following the Civil War. So essentially, nurses training historically started in the churches, the Christian churches, taught by monks. Then it evolved from there. Where did it go from there? Then we're going to talk about, remember Phoebe? I talked about Phoebe. She was one of the, I'll say an ancient nurse. She has a broad history, which I'll touch on her again in a second. But going back to North America, it was basically an apprenticeship. If you wanted to be a nurse, you can expect some hospital-based training that lasted from, well, your book says anywhere from 6 months to 3 years, but I've read research articles where it was as little as a 3-month program. Now, this is in an era when women were expected to remain home, stay-at-home mom, housekeeper, okay, and really catering to the opposite sex when coming home, right? Taking care of the man's needs. And I'm speaking in an aspect from your book. And as we know, women's rights has evolved from there. But it wasn't until the United States needed more staffing of nurses. Okay, so now we're starting to get nurses going into apprenticeships. We're starting to get nursing schools coming up. Okay, some U.S. nursing schools. They called it the Nightingale Program, and it was well organized, and they held classes for practical nurses and gave them experience on the ward. And again, instruction was provided by a trained nurse and focused in nursing. All right. And I'm kind of getting away from the PowerPoints. I really want to touch on some things that I feel are important. Okay. Let's see here. We want to discuss how nursing is both a science and an art. We promote wellness, we prevent illness, we help with coping, and our goal is to restore optimum health. If you're following along in your book, you can find some pictures on page 3 of your book of how nurses historically dressed, who they served, and how they were trained. Now, continuing on to page 4, and I'll be jumping through some of these just because I've already touched on them previously in our class. I'm on page 4, and we're going to talk about medications and how to aseptically change dressings, which are an example of what you can find in your role under your licensure. Okay, and I want to say that aseptic technique is something that prevents illness, is something that prevents you to touch something while passing it to another. So in accordance with your PowerPoint, on this slide, it's talking about eligibility to become licensed as a nurse. Well, each state has their own tests that you'll take, but each one is governed by the National Council of the State Boards of Nursing, which is the people who develop the NCLEX exam. You have to pass the NCLEX PN as required in all states. We do have a nursing compact licensure, which once you get licensed, when you do your application to take this NCLEX test, you want to choose compact or multi-state, which would allow you to travel. Okay. Now I'm going to continue on with your PowerPoint for a minute. Student nurses. We also discussed in class how essentially you can be sued, that you're responsible for your own action or inaction, failure to recognize. And you have an ethical and mandated responsibility to consult with your instructor anytime you're unsure of a situation or when a patient's condition is changing. Let me touch on clinicals, for example. In a clinical environment, you will enter the facility with your instructor only. You'll be giving an assignment, possibly in pairs. Sometimes we like to start out PNs working in pairs and taking care of one patient. But in that care of a patient, if you take a blood pressure and you just learned about vital signs that normal is 120/80 or less, and you take a blood pressure on the patient that reads 150/100, you are responsible to immediately instruct your instructor about the findings. And then, of course, reviewing your State Practice Act both as a practical nurse and a student nurse will help you understand the outcomes and expectations of your roles of each one. In nursing, we must hold ourselves accountable. Nursing is traditionally the most trusted profession. With that is because of our high integrity. We have a high level of integrity as nurses. We do the right thing always when no one's looking. That is the essence of nursing. We care for the sick, the dying. We care for CEOs and big executive chiefs in corporate companies. However, we treat both the same. There is no VIP in healthcare because disease, does not care who you are. Genetics play a role, doesn't care who you are, what you do, where you're coming from, where you're going. That is why we care for the homeless as much as the CEO or even high profile persons. They get the same care. We are mandated to utilize the nursing process in such a way. And speaking of the nursing process, I want to tell you that the nursing process compromises your nursing assessment, diagnosis, planning, implementation, and evaluation. That's a way that we like to implement care. It's called the nursing process. And that encompasses both the art and science of nursing. The nursing assessment is where you're gathering data, you're listening with your stethoscope, also called auscultation, listening with a stethoscope, that's part of your assessment. Getting subjective information, meaning subjective, what the client said to you in their own words. And objective information, objective is anything that can be measured. I can measure a heart rate. I can't measure an emotional state. If you're mad, I can't prove you're mad. If you have a headache, I really can't prove you have a headache, but I can assess it. Planning. How are we going to plan safe and effective care? Do I need to plan for this patient to go to physical therapy after the patient has suffered a stroke? And I assess that they have maybe left side flaccid arm, or other words, their arm is not working, doesn't lift up, doesn't move. Okay, implementation. The action part of nursing, what you're actually doing for the patient. You do not document something unless it happened. If you didn't document it, you didn't do it. Evaluation, which is ongoing. Evaluation is part of the nursing process, where after you implement care, you have to follow up and see how the patient is doing. For example, if you walk into a patient's room and you want to exercise the nursing process, you start with an assessment. And they tell you that they have a headache during your assessment. Your nursing diagnosis can include some of the findings that came from your assessment. Maybe they're sensitive to light. So one of your nursing diagnoses is photosensitivity or sensitive to light. At risk for nausea related to a headache. I have a video that I will share with you on how I explain and utilize nursing diagnosis and the book that goes with it, which is included in your tuition. Planning. You plan to give the patient a Tylenol. Implementation is where you go to the med cart, you grab that Tylenol, and then you follow your rules of medication administration and you give the patient the Tylenol. That's implementation. You actually did something. And then evaluation is where you go back an hour later after they swallow the Tylenol and reassess their headache. Did it help? Did it not? And then you document your findings, called charting. Let's continue here. So again, you can follow along in the PowerPoints. I'm also speaking on certain key points from the book, so I would take notes. But let's digress for a second. Regarding Nurses Practice Acts, I want you to think about the State Board of Nursing. Okay, that's where we report your hours didactically, clinically, from the lab, and from simulation, and they determine nursing education requirements as needed for licensure. Okay, and as within a specification of the legalities of nursing and the titles. Okay, so remember, the State Board of Nursing for each state, you can choose the multi-state, or you can choose your home state where you live, where you went to school. All right, and again, that's the State Board of Nursing. How do we make our curriculum? How do we know how many clinical hours that you need For example, your next course where you start going to clinicals, we don't just dream up that you need 90 hours of clinicals. That comes from the State Board of Nursing for Florida, okay? Florida, because everybody that goes to this school lives in the state of Florida right now. That's why you're attending school here. So you got to think about that. Remember those things. Those are key items. Continuing on, Chapter 1 also talks about evidence-based practice. An evidence-based practice describes nursing care that uses the best research evidence coupled with clinical expertise of the clinician, considering the values of the patient. So in nursing, lots of research is done. The further you go in your nursing education and licensure will bring on a new layer of research that you will understand and or be responsible for. Okay, we call that evidence-based practice. And like I said, it's based on current research and clinical expertise. You can find that on page 4 under evidence-based practice. All right. Sometimes the best way to learn these newer chapters is to make flashcards of the vocabulary words. Continuing on with evidence-based practice, I want to talk about your next vocabulary word. It's called best practices. Best practice means the use of care concepts, interventions, and technique that are grounded in research and are known to promote a higher quality of care and living. Okay? Clinical field expertise and evidence-based practice are used to establish the best practices for nursing care. Best practices are often provided in the form of clinical practice guidelines and or policies. Okay? And this is why nursing is the same throughout the United States and internationally, because we follow certain clinical practice guidelines as far as best practice. Okay? For example, you will learn this. It is best practice for an IM or intramuscular injection to use a 20 to 22 gauge needle with an inch to an inch and a half length. That's best practice. So if I was on the floor right now and I was ordered an IM injection to give a patient, I would look for a 20 or 22 gauge needle, an inch or an inch and a half length, depending on body habitus or size of the patient, how deep I'm going into the patient. But my clinical practice tells me it's an inch to an inch and a half. So I will choose. Does it warrant an inch needle? Or does the patient have a little extra fluff and I need an inch and a half needle? That's following guidelines, clinical practice, which is best practice. I would not grab an 18 gauge needle, 1 inch length. That is not following clinical practice guidelines. Okay? That is not conducive to their plan of care either. Okay? Meaning, nurses, we do not get creative in our care and dream up things to do or how to do something or shortcuts. We follow what we learn in nursing school, what a nurse has taught you, what your licensure expects you to learn, what your exams test you on, what your quizzes test you on. This all relates to best practice. And again, that is essentially where you're following your clinical practice guidelines. Okay? And it's specific to the patient care plan. Let's continue on here. This is good. Next, I'll go back to the PowerPoint talking about delegation. Delegation is where you assign duties to another person. But in assigning duties, you must be prepared to train and supervise. An LPN, you may supervise CNAs, technicians, or other LPNs. If you're an LPN supervisor, you may supervise an LPN staff nurse. Okay, you may supervise PCTs or patient care technicians. Or you may supervise nurse technicians because you're the licensed professional and they have not achieved licensure yet. But in doing so, you must know if the person you're delegating to has done the skill or not. Have they been checked off? Have you seen them? You can train them or teach them and ask them to do a return demo. We talked about the State Board of Nursing and Professional Discipline. Did you know it is considered negligence not to report another professional's misconduct? That relates back to integrity. Here are the most common charges brought up against nurses: substance abuse, incompetence, failure to recognize, and negligence. Okay. We talked about how it is dedication to lifelong learning. Many states have laws that mandate you to continue your education after you've been licensed. We call those continuing education, or CEUs, if you're familiar with HCA. We call that, which is called Health Stream. We call that e-learning in the world of Cleveland Clinic, is where you provided online learning to continue your licensure. And also, these are regulated and mandated for you to renew your license every 2 years. You have to have X amount of hours based on your State Board of Nursing's licensure requirement, even after licensure. Okay. Here are some laws and guidelines that affect how we practice. We have to pay attention to getting consents and releases, especially for any patients undergoing an invasive procedure. We have to maintain HIPAA, Health Insurance Portability and Accountability Act. You may see that again. We cannot share patient information. If you're on the elevator at clinical and it's you, a student, and another person in the elevator, and you start talking about a patient and you didn't know that that's their mother, you can be sued. You've just violated HIPAA. You and the facility could incur fines. We must pay attention to national patient safety goals, which can be found on their website. We have to respect the patient's right. They do have the right to refuse. Good Samaritan law covers you. If, let's say, you're traveling down I-95 and you witness a car hit another car and somebody ejected, if you go and check on the ejected patient, you're covered if you're providing life-saving measurements or helping out during an emergency or accident outside of your practice area. Meaning if you're a hospital worker and someone is injured on a roadway and you stop to help, the Good Samaritan law is a blanket that covers you. Be mindful of sexual harassment, Child Abuse Prevention and Treatment Act, discrimination, and of course, occupational safety and the Healthcare Act. Okay. We are mandated to report child abuse, elder abuse, any type of abuse. Occupational Safety and Health Administration, we call that OSHA. They handle infectious and toxic materials. They handle safeguards, radiation, and electrical equipment. They also require that we utilize education and one second. Sorry about that. Forgive me. I had to step away for just a moment. Let's see, where were we? Okay. Let me get through this slide here. Talked about OSHA. Okay, so this requires education on the topic of bloodborne pathogens exposure to fire. So OSHA mandates every clinical orientation we do. When we go to a clinical site, we have to be oriented both on campus first and then at the facility because of OSHA and other legal requirements of. Okay, so in this slide, you can see examples of what they're going to talk about, what you can expect for every clinical rotation. Let's keep. Okay. This is a PowerPoint on child abuse and the Prevention Act. We call it the CAPTA Act. Again, we are required to report child abuse. We look for signs of child abuse, especially in pediatrics. So when you do your pediatric rotation or clinicals, you should be expected that you're going to review this information. Again, this is an introduction. We do not discriminate. We do not discriminate. We do not discriminate. Nurses are a non-judgmental. We heal for all. Okay. This should be self-explanatory. However, as a nurse, remember I said earlier, we don't care what you do, who you do, how you do, when you do. We will treat you with kindness, honesty, respect, and we will take care. We are committed to care, no matter what the circumstances are, and we keep personal and family matters protected. Okay? Sexual harassment, this goes without saying. Okay, we need to be mindful when we're providing care or working or collaborating amongst other healthcare. Like I was saying, the Good Samaritan law, this protects you from liability, okay, if you stop to provide aid in an emergency. Patients' rights, this is huge. We must be ethical, okay? We need to preserve the dignity, privacy, and freedom of movement and information needs of patients. National Patient Safety Goals. This comes from sentinel events. When a patient dies unexpectedly, falls, dies, or a serious injury to life or limb happens, it gets analyzed, it gets reported, and then they come out with these national patient safety goals, which we are supposed to remain abreast of. Okay, so we can facilitate safe and effective care as related to the NCLEX test plan for PN. Here's an example of negligence and malpractice. Failing to do something a reasonably prudent person would do. So example, if you've been trained for X amount of years and you do something that another nurse would not do, especially a prudent nurse, you can be sued for negligence. Malpractice, again, not acting according with professional standards of care or your best practices that a prudent professional would do, meaning a meticulously professional person, someone who interacts based on education and policy standards. Before I get into the chart, let me digress on this slide, and I'm going to come back to a portion from the book. Okay, now I'm still in, let's see, I'm still in chapter 1. I'm going to make sure we covered the practice acts. We covered the nursing process. Again, and these are all highlighted in blue. They are in blue bold print. I would make flashcards on these. I'd also would read box 8.1. Okay, on page 6. Let's see here, what else? HMOs, we're going to get to HMOs, DRGs, those are fun. Okay, I'm going to move a little forward, and again, it's your expectation that you read chapter 1. I've highlighted some key points from chapter 1. I would like to get into chapter 2 right now, concept of health, illness, stress, and health promotion. Let's talk about this. So you have some key terms, and again, understanding the key terms is going to be paramount. I want you to be able to differentiate the difference between chronic and acute. Okay, chronic is lasting 3 months or longer. Chronic illnesses can be controlled, like through medication, one example, but they're not cured and they're often lasting longer than 3 months. So 3 months is the key. Anything lasting longer than 3 months is chronic. Again, can be controlled with medicine, can be controlled with other regimens, other modalities. Okay, maybe physical therapy or certain other therapies. Acute is something that happens quickly in a short time. We're hopefully our common cold is just acute. You're acutely ill for like 2 weeks or less. So it's anything 3 months or less. Essentially, it's something shorter than that. Okay, so for example, cirrhosis is chronic. Type 2 diabetes is chronic. Heart failure is chronic, right? We don't just get heart failure and it doesn't get fixed in a matter of 1 month and be done. No, acutely sick is like a head cold, an injury, things like that. Okay, so you have to know that. Speaking of patient rights, do you think the client has the right to refuse medications or diagnostic studies or treatments if he's lucid or competent like you and me? Yes. Yes. As long as a patient is competent, meaning that they are of sound body and mind, sound mind, okay? They know their LOC is intact, okay? That means that can they can consent regarding medications, they can consent regarding treatments, they can consent regarding any invasive procedures, okay? And LOC means level of consciousness. That's how it's basically the patient's awareness of self and surroundings, okay? If I'm walking into the patient's room, I'm swiping in. I'm identifying myself and washing my hands. I'm introducing myself, okay? Of course, provide privacy for the patient. And then I'm going to assess their LOC. I've looked at their name band. I've asked them their name and their date of birth. That's their two patient identifiers. And then the next thing I'm going to do is ask them, what brought you in today? Is it something acute or chronic? Well, if he tells me he came in for heart failure, that's chronic. It's lasting longer than 3 months. Okay, so they came to the hospital to get it treated. I'm going to ask the patient what day it is. They should be able, if a competent patient can tell me the exact date that it is. Okay, they may not know the time because they've been in the hospital, but they need to know the day and the year and the month. Okay, they need to know, you can ask them paramount information like who the president is. That's general knowledge. Okay, tells us what era that they're in. Okay, and then once you assess their LOC, you can deem as competent or not. In certain cases, the doctor may have to order certain exams or certain consultations to deem if a patient is competent or incompetent. But normally, PNs, you're getting patients who are essentially stable. They may not have competency, but majority of the time they still do. Okay, and if they have competency, they can refuse a lab draw, a blood draw. Okay, they can refuse medications, treatments. They can refuse discharge if they feel it's unsafe, and then you have to verify why the discharge is unsafe. Okay? So pay attention to the things that I'm saying. All right, let's keep it rolling here with chapter 2. How do we promote health and wellness? Okay, and again, I'm in the book right now, so just bear with me on the PowerPoint slide. How do we prevent health and prevent disease, promote wellness, promote health? It's through education. It's through best practices. It's through evidence-based practice of staying abreast of current situations and states in nursing. Okay. The definition of disease is a pathologic process that causes illness. Again, both acute or chronic. Acute illness is one that develops suddenly and resolves in short time, like the flu. Okay? A chronic illness, such as hypertension, is one that develops slowly. It can be controlled, but oftentimes it's not cured and it's long lasting. Then you have the term a terminal illness, which is one that has no cure and it ends in death. Cancer, terminal illness. Talking about subjective. Okay. What I discussed earlier regarding objective. Moving forward here. Let's see here. Health and wellness. Now, if we say the word symptomatic, what does that mean to you? That means that they're having symptoms. They are objectively having symptoms. If a patient says, I have palpitations, okay, we need to measure. Are they tachycardic? Let's listen to their heart. Those are objectives. Okay. When we're thinking of planning care, whether it's acute or chronic care, we need to take into consideration again the nursing process, okay? And we plan our care based on interventions that we deem are appropriate to improve the client's health and wellness, okay? So when planning care, I would not do something that would harm the patient. That is against what we stand for in nursing, okay? Let's see, we talked about this. Okay, let's continue on because I want to get to Maslow. Love Maslow. Let's talk about holistics. A holistic approach to caring for the sick and promoting wellness. A holistic approach is one that considers a person's biologic, psychological, sociological, and spiritual aspects and needs. Okay? This is wonderful. Holistic nursing is probably the epitome of nursing, in my own opinion, because the person is valued as a human being. They're valued as a person for who they are through each aspect of their life or what's important to them. We strive to help with patient deficits. We strive to care for the patient not as a disease process but as a person. Okay? And there is a very important depiction in your book. It's called Maslow's Hierarchy of Needs. It's a pyramid, and the pyramid has certain topics to it that are extremely important for test-taking purposes, how to answer questions, and how to prioritize care. Let me talk about the Maslow's hierarchy of needs, for example. This is, so if we talk about the pyramid, the base of the pyramid has to do with oxygenation, nutrition, elimination, safety, rest and comfort, hygiene, activity, and sexual procreation. Okay? The hierarchy is defined as the arrangement of objects, elements, or values in order of importance from Dr. Maslow in 1970, who created this pyramid. Maslow's basic needs are the foundation of the nursing practice, nursing education, and prioritization. So basically, in a question of which patient you're going to see first, how you can think to prioritize or prioritize care. Theoretically, the basic physical needs, okay, are food, air, water, and rest. That must be satisfied before the higher emotional level needs emerge, okay? And again, paying close attention to this, let's talk about physiologic needs. Fundamental physical needs, aka physiologic needs, are essential to maintaining life. The first physiologic need is for oxygen. This is immediately followed by the need for adequate cardiovascular function to supply tissues with blood, or the need for adequate nutrition and for elimination. Those come next. Those are basic needs that are almost as important as physiologic needs. If the patient cannot be protected from dangers of being burned or a severe fall, attending their physiologic need is useless. So we need to protect them from harm, keep them safe, okay? Safety. Safety. And I can't say it again, but safety, okay? We consider physiologic needs protecting from harm. We consider physiologic needs as which include oxygenation. That's one of the top priorities, which is the base of the pyramid, the very bottom that you would start to climb the pyramid. Okay? Self-actualization is the last part, and that is at the very tippy top of the pyramid. It is the smallest area of the pyramid. But let's talk about the next one, security and belonging. Security meaning psychological comfort, so comfort of the mind, okay? Calming a patient down, security. Assistance in meeting needs, a comfortable environment or milieu, okay? Belonging, social interaction, communication, human being, and the family community. That's the next area of the pyramid, right above the base of the pyramid, okay? Which is the physiologic area. Now, once the basic physiologic needs are satisfied, then you can move up the pyramid to safety and security, but you must start at the base of it, okay? Self-esteem and love, that comes next. That's in belonging, okay? So love, giving and receiving affection, intimacy, sexual expression, social interaction. Oh, I said that already. Pardon me. Let's continue on. A lifespan consideration, okay? If someone comes into an adult's room or rearranges their belonging, it can threaten how they feel and their security because they no longer know where things are. So be advised that when you're going into these patient rooms, don't just rearrange to your likings. Keep it the way they had it, just keep it clean, okay? So Maslow is something you definitely need to know. Please definitely study Maslow, each part of it. Remember what goes under physiologic, what goes under psychologic, what is security and belongings, okay? Security meaning they need to know what's happening with them, right? That's how they know that they're gonna get psychological comfort. Like if they ask you a question or are they scared? We need to pay attention to that. Let's see here. What else we talk about here? We talked about that. let's continue on with chapter 2. Now, I'm going to skip forward on the pyramid. I want to talk about self-actualization. That is the very top. You cannot get to the top without climbing from the base first, okay? Building blocks. That's reaching one's fullest potential. It's a stage which people do not advance until the physiologic security, belonging, self-esteem, and love has been met. Self-actualization occurs when individuals are comfortable with themselves and are certain of their beliefs and values. They're self-reliant, they're flexible, they're open-minded, and they seek out knowledge and truth and function close to their full potential. Okay? It's an ongoing process. It's not something you reach at a particular time. It is definitely something ongoing. Nursing actions that facilitate self-actualization are pertinent mainly during rehabilitation periods when the nurse assists the patient in striving to achieve their full potential. Okay? Because what do we do as nurses? We promote wellness. We assist with coping. We prevent illness, and our goal is to restore optimum health. Let's see, continue on here. All right, let's keep going. Back to the PowerPoint. And release. Legal form to excuse one party from liability. Example, when a patient leaves AMA against medical advice. I've had patients that have left the hospital, okay, both under my care or when I was assuming a charge nurse at hospitals in the area, that people do leave AMA, and that's okay, but they must sign a release form. There's some examples where on the release form I said the patient is at risk for death, okay, related to whatever was going on with them. If I got a patient who's hemorrhaging and they want to leave AMA, okay, if they have an internal hemorrhage, or whatever example that we can use, but I'll use that one, and they want to leave AMA because they can actually walk. Until they can't walk, they could collapse from anemia, from the hemorrhage internally, maybe like a GI bleed, okay? We can't let them go. If we let them go, that's a huge problem, and they're leaving against medical advice. They need a release form, okay? Ah, yes. Witnessing wills or other legal documents. One of the most predominant legal document that you'll find in healthcare is power of attorneys and advance directive. And let me digress and talk about an advance directive. Okay, find the page number for you. An advance directive, that is in chapter 3, you will find it in advance directive. But I want to tell you what your book says about it. An advance directive, that's your living wills, last will and testament. It's a consent that has been constructed before the need. Everybody should have an advance directive because God forbid that something happens, get in a car crash, become incompetent, unable to make decisions for yourself. Who's going to take over? Where are your children going to go? What's going to happen to your house, to your bank account, to your business, to every aspect of your life, to your assets? Okay, a living will it spells out a patient's wishes regarding surgeries, diagnostic procedures, therapeutic treatments. It's a clear direction for making decisions. Okay, so the person that you leave in charge, they must be able to make decisions for you. That's an advance directive. Okay, a power of attorney, on the other hand, makes like the business decisions. Okay, and it's a release of responsibility used to excuse one party from liability. So think about power of attorney. That's like the business end of it, taking care of bank accounts and monies and this and that. But the advance directive is what we want to see in the hospital. That is predominant. It tells us that, hey, this patient has an advance directive or a living will that provides consent, which can possibly help out with surgeries, okay, or treatments. So please make note of that. There we go. They do have in here, this slide includes durable power of attorneys, but again, more of business acts that we want to know that does their advance directive cut out what they want done for them, even medically, medical wishes, okay? That's a plan. And again, everybody should have one. Before we get further into chapter 3, let me digress back to chapter 2. Let's go to homeostasis. Okay, homeostasis is maintaining an equilibrium amongst the bodily environments. Okay, you must make note of that. This is where our body regulates what's going on through hormones, through the brain stem, through the spinal cord, through temperature regulation, homeostasis, okay? And I'll read you what it is from the book. It's a term first coined by W.B. Cannon back in 1939, described as a tendency of biologic systems to maintain a stable internal environment by continually adjusting to changes as needed for survival. Okay. Stress disturbs the organism's homeostasis and causes the body to attempt to adapt. So we must remember that our body is a constant battleground. And in that battleground internally, we need to maintain the balance or equilibrium known as homeostasis. Okay? Let's see here. Let's see. Parasympathetic nervous system, sympathetic. We talked about that. Okay. Talked about health promotion. We'll get into disease mechanisms as well, but I'll keep that for chapter 17. Let's talk about primary prevention. That avoids or delays occurrences in specific disease or disorders. Secondary prevention consists of following guidelines or screening for diseases that are easily treated if found out early. Tertiary treatment or prevention consists of rehabilitation after a disease or disorder has been stabilized. Let me give you some examples of those, okay? So let's talk about primary prevention. It's like wearing your seatbelt, eating well, not smoking, getting immunizations or your annual flu, exercising regularly. Those are some examples of primary prevention. Secondary prevention is getting a screening, pap smears, testicular self-exams, mammograms, colonoscopies as recommended by age. Okay, getting skin tests like a tuberculosis screening or TB test, or having routine tests like visual eye exams. Okay, that's prevention. Tertiary prevention, for example, pursuing rehabilitation programs after a stroke. Okay, so let's say, if for a good example, primary prevention, if you know that your family suffers from hypertension or high blood pressure, you should utilize primary prevention of eating well-balanced meals and exercising regularly and maintaining the proper body mass index or BMI. However, if you fail to do primary prevention, secondary may catch it. Meaning, did you have your blood pressure screened? Like for a blood pressure prevention, as secondary prevention. If you didn't do that and you had a stroke from hypertension, you may need to seek out rehabilitation services to regain your strength in the rehab program that's part of tertiary prevention. That's an example you can utilize. Okay. Let's continue on here. I'm gonna brush through chapter 3. Assault and battery. Woof. Assault is a threat to harm, or even threaten to touch another without that person's permission. Battery. Actual physical contact that has been refused or that is carried out against the person's will. Nurses, we have to be very careful on how we touch our patient. We must get permission when listening to the heart sounds. Is it okay if I listen to your heart and lungs? And the patient answers you yes. Good. Is it okay if I lower your gown to get a better listen of your heart and lungs? I'm going to expose you now. Yes. Please continue. Then you got consent from a competent patient. Okay? We must be prudent in the way we approach patients. Okay? Do you know if a client has an armband on that says DNR, do not resuscitate, and you're a new nurse on the unit, you go into the patient's room, you find them unresponsive, and your training tells you to start CPR and initiate chest compressions? Wait a second. Is that right? The patient has the armband on that says do not resuscitate. That could have been a part of their advanced directives or living will, that they want to die naturally, and do not bring them back to life, please, because that is what is delineated in their advanced directive. You just committed battery. You can be sued. Okay? Please keep in mind that battery is the threat to harm another or even threaten to touch another without the person's permission. They didn't give you permission to resuscitate them through their advanced directive. Now, if they were a full code and you walk into a room and they're unresponsive and you start CPR, initiate chest compressions, you're a hero. You're a nurse. Okay? But if it's the other, we have a problem. Okay? Sorry, battery is actual physical contact. I explained that last one wrong. But the same would stand. So you didn't have permission to physically touch this patient because they're a DNR. You're carrying out care against their will, aka advanced directive. That is battery. Battery is the actual and physical touch. Okay, let's continue. Remember your scope of practice. Student nurses are held to the same standard as licensed nurses. This means although a student nurse may not perform a task quickly or as smoothly as the licensed nurse, the student nurse is expected to perform it as effectively. In other words, the outcome must be achieved without harm to the patient. The student is legally responsible for their own action or inaction, and many schools require the student to carry malpractice insurance. That's from your textbook. For the instructor, we are responsible to supervise the student. That is responsible for proper instruction, adequate supervision, and evaluation of the student. Okay, and we assign based on appropriate level of complexity as to not jeopardize patient safety. You're responsible to consult with your instructor in unsure situation, just like my previous delineated. Talked about licensure statute. A tort is a violation of civil law. You may be guilty of a tort if you harm a patient, for example, by administering the wrong dose of medication. A lawsuit can result, and the defendant is found guilty. A monetary reward will be given to the plaintiff. Okay. Be careful, be careful, and be careful. Make yourself aware of the legal terms. Okay. Found in this chapter. Defamation of character. is remarks about another person that are untrue and damage their reputation. Slander is oral, libel is written. Invasion of privacy. This is huge, okay? You're breaking confidentiality and privilege of the patient, meaning a violation of the confidential and privileged nature of professional relationship. We keep familial matters and patient matters to ourselves. We do not break HIPAA. We do not invade privacy. Okay, that's why we tell you not to go on Snapchat and post a snap that include any identifying factors of the patient, like their name, their date of birth, where they're located, what hospital, what's going on with them. Okay, that's a problem. False imprisonment. When an involuntary admission is made against the patient's wishes. We need to protect the patient from self-harm. Okay, or preventing a person from leaving or restricting movements in the facility. Don't put all 4 bed rails up. You're restraining them. Okay? False imprisonment. Again, protective devices, your restraints. You cannot, most places are getting restraint free now, but these can result in charges. Devices can be mechanical, such as a posy vest, which should be outlawed in my opinion. Most places it has been. And chemical, if you give them Benadryl to knock them out, or any other psychoactive drug to change them. Okay. How do we decrease all these risks? Well, competence, your competence, proper instruction, dedication to the profession. It's through incidents and occurrence reports. We analyze data and having liability. Lawsuits may be avoided with early identification of dissatisfied patients, your HCAPs, your surveys that you do, documentation. Okay, documentation is a way to cover yourself that you, the competent nurse, acted as a prudent nurse would, that you possessed a certain knowledge and skill required for the profession. Okay. If a patient falls, we complete an incident or occurrence report. What happened? Was it witnessed? Was it not witnessed? Okay. Um, Sentinel events. Liability insurance. This helps protect livelihood and assets of the nurse in the case that the nurse got sued. It can help with lawyer and legal fees. Ethical. Is it right what you're doing? Is it mandated what you're doing? Is the care you're performing competent? Have you done it before? Okay, all those things should come to mind when you're in nursing. We have to follow a code of ethics and uphold the profession by providing human dignity. And the provision of care is not affected by race, religion, or lifestyle or culture. Okay? We have to stay abreast of current changes. If there's a way that is new to do something, we must follow it. And keep everything nurse to patient. Here are certain ethical dilemmas. Some of them are like euthanasia, that is the popular one talking about right now. How they're starting to legalize euthanasia in Europe. I don't know if it's happening here in the US. Abortion is one of them. Initiating or terminating life support or treatment, or life prolonging treatment versus refusing treatment. These are ethical dilemmas, and when you're presented to them, please don't feel alone in nursing. You present it to the ethics board or committee in wherever you're working at, and they will help you through this very sensitive area. Standards of care, right? It's a way of judging the quality and effectiveness. In the legal cases, it determines whether you, the nurse, acted appropriately.